Welcome to this comprehensive guide on hypovolemic shock. Hypovolemic shock is one of the most critical emergencies encountered in nursing practice. It occurs when the body loses a significant amount of blood or fluids, leading to inadequate circulation and poor tissue perfusion. In this presentation, we will review the underlying pathophysiology, key assessment findings, causes, and essential nursing management priorities. This step-by-step approach will help strengthen both your clinical understanding and exam preparation. To understand hypovolemic shock, we must first understand normal blood volume and physiology. The average adult has approximately 5 liters of circulating blood. This volume ensures adequate perfusion of vital organs, supports oxygen delivery, and maintains organ function. Stable blood pressure, effective cardiac output, and sufficient urine output are indicators of adequate perfusion. When circulating volume drops significantly, the body can no longer maintain homeostasis. Recognizing early deviations from normal physiology allows nurses to intervene before shock progresses. What is hypovolemic shock? Hypovolemic shock occurs when there is a significant decrease in blood or body fluid volume. First, volume loss occurs. Second, circulation to vital organs is reduced. Third, tissues receive insufficient oxygen and nutrients. Finally, if untreated, organ dysfunction and failure develop. As blood volume decreases, less blood returns to the heart. Cardiac output falls, blood pressure drops, and tissue perfusion becomes inadequate. Early recognition and immediate intervention are essential to prevent irreversible complications. Causes of hypovolemic shock. Hypovolemic shock can result from several underlying causes. Severe bleeding is a major cause. This includes trauma, surgical complications, postpartum hemorrhage, and gastrointestinal bleeding. Fluid loss from the gastrointestinal tract can also lead to shock. Examples include excessive vomiting, severe diarrhea, prolonged nasogastric suction, and intestinal obstruction. Burns and heat-related conditions cause significant fluid shifts and loss. Renal losses, such as diuretic overuse, diabetes insipidus, or acute kidney injury, may also contribute. Understanding the cause is crucial because management strategies may differ depending on whether blood or fluid loss is involved. 2 types of hypovolemic shock. There are 2 primary types of hypovolemic shock: hemorrhagic and non-hemorrhagic. Hemorrhagic shock results from actual blood loss. Both red blood cells and plasma are lost, reducing oxygen carrying capacity and circulating volume. These patients often require blood transfusion in addition to fluid resuscitation. Non-hemorrhagic shock results from fluid loss without significant red blood cell loss. Causes include vomiting, diarrhea, burns, and excessive sweating. In these cases, isotonic IV fluids are typically sufficient initially. Both types reduce circulating volume and impair tissue perfusion, requiring rapid intervention. Pathophysiology. The development of hypovolemic shock follows a predictable cascade. It begins with fluid or blood loss. This leads to decreased venous return to the heart, reducing preload. Cardiac output then decreases. Blood pressure falls as compensation fails. Tissue perfusion declines, causing cellular hypoxia. If prolonged, organ dysfunction and multi-organ failure can occur. This progression highlights the importance of early detection and aggressive management before irreversible damage develops. Signs and symptoms. Clinical signs of hypovolemic shock can be divided into early and late findings. Early warning signs include tachycardia, cold and clammy skin, pallor, restlessness, thirst, and increased respiratory rate. These are compensatory mechanisms as the body attempts to maintain perfusion. Late signs indicate decompensation. These include hypotension, weak and thready pulse, decreased urine output, altered level of consciousness, cyanosis, and metabolic acidosis. Reduced urine output is a critical early indicator. In adults, less than 30 milliliters per hour signals worsening renal perfusion and requires immediate action. Nursing management priorities. Management of hypovolemic shock must be immediate and systematic. First, ensure airway patency and administer supplemental oxygen to maximize oxygen delivery. Second, control any active bleeding using direct pressure and notify the physician immediately. Third, establish 2 large bore IV lines for rapid fluid administration. Administer isotonic crystalloids as ordered, and monitor for fluid overload. Continuous monitoring of vital signs, mental status, skin condition, and capillary refill is essential. Insert a urinary catheter to closely monitor hourly urine output. If hemorrhagic shock is present, prepare for blood transfusion. Surgical intervention may be required in severe cases. Exam quick reference. For exam preparation, remember the classic triad of hypovolemic shock, low blood pressure, typically systolic below 90 millimeters of mercury, fast pulse rate, usually above 100 beats per minute, low urine output, less than 30 milliliters per hour. Focus on trends rather than isolated readings. Small changes can indicate deterioration before severe symptoms appear. Accurate documentation and clear communication using structured handoff methods are essential in clinical practice. Above all, remember that hypovolemic shock requires rapid recognition and aggressive fluid resuscitation. Early nursing intervention can be life-saving.